Hi, Dr. Cady here, and this is a follow-up to the video that I recorded yesterday about what do Freud and menopause have in common. And my take on that in terms of functional medicine and hormone replacement therapy is that one should listen to the patient and actually hear what the hormones are telling you. In fact, again, coming from my psychiatry background, there was a psychiatrist named Peter Kramer who was very elegant, and he practiced in New York City. And because he was both a therapist and a psychoanalyst and a prescribing psychopharmacologist, a psychiatrist that prescribed medication, he got lots of referrals from therapists for patients that were not doing well. And Kramer, when Prozac came out, said that he took all of these patients that were referred into him for depression and he put them on Prozac. And he said, as he listened to the patient after they had been on Prozac for a while, it was like he stopped listening to the patient and started listening to Prozac. And that was the title of his book about Prozac, Listening to Prozac. When my patients come in and they tell me these disparate things in their life, like no sex drive, can't sleep, mean, irritable, and ornery, can't focus, can't think, can't stay organized, I listen to their hormones. And yesterday we were talking about the different hormones. Progesterone, which is good for sleep and calmness and feeling good. Estrogen, which is nature's own monoamine oxidase inhibitor. And testosterone, which gives one energy. So today I'd like to break them down a little bit more and talk about how you can take them. And in a moment, I'll tell you about troches or troche and some other fun things. But let's talk about treatment for menopause. So back in the early to mid 90s, there was a paper that came out called the Women's Health Initiative Study, and it purported to show that hormones are dangerous. And the conclusion was that for a woman to be on hormones, she should be on the lowest possible dose for the minimum possible amount of time, and she should get off of it as soon as possible because hormones, you see, caused heart attacks, strokes, breast cancer, and dementia, as they called it. This was the notorious Women's Health Initiative study. There were several problems with the study, and basically, I'll cut to the chase, the results were interpreted badly. So what the Women's Health Initiative study, what its jumping off point was they looked at women who had been on hormones, Prempro at the time, which I'll tell you about, Prempro for, ever since menopause, and they were doing well. Their skin was good. They weren't having hot flashes. They weren't having night sweats. They weren't irritable, mean, and ornery. Their brain was working okay. Their sex life was good. Everything was just hunky-dory. So the geniuses that set up the study decided to answer the question, gee, what would happen if we waited for a decade after menopause and then we put women on this stuff? Well, the interesting thing is the stuff that they were using, and which I used in medical school, I did it, this was standard practice, were these two things called Premarin and Provera. Premarin is more generically described as conjugated equine estrogens. Now, let me tell you what that means. It means it is estrogen which is extracted from horse pee. Mares are impregnated. They stand in stalls. They have a catheter put into them, and they just serve as manufacturing factories of horse pee estrogens, which are then harvested and processed and then sold for hormone treatment in women. These women were treated with Premarin, conjugated equine estrogen, which is not bioidentical. It's bioidentical if you're a horse and you're looking at the pee. It's not bioidentical if you're a human female. And they were treated with medroxyprogesterone. The brand name is Provera. So this is what the study purported to show. First of all, the conclusion was hormones are dangerous. Well, yes, hormones are dangerous if you give women fake hormones 10 years after menopause. We don't do that. In fact, I've never given a fake hormone here at CWI. And my nurse practitioner, when she was here, she never gave a fake hormone. We give bioidentical hormones, and I'll tell you what those are in a second. It's actually more interesting than you might think. So the women in the study allegedly had more breast cancer, more heart attacks, more strokes than the placebo group. Here's how it actually played out. There was a placebo group, there was a Premarin, horse pea estrogen group, and there was a Premarin and a Provera group versus the placebo group. So the horse pea estrogen group, the Premarin group, in terms of their breast cancer, they actually had less risk of breast cancer than the placebo group. And it's computed in terms of a relative risk. If you establish 1.0 as the relative risk for getting breast cancer in the placebo group, which is just a standard risk, and then you looked at the risk for the horse pea estrogen treated group, Premarin, the relative risk was 0.98. In other words, it was less than the placebo. So you could not say that estrogen caused breast cancer. That's been widely misreported, and it is just flat wrong. Now, where did the breast cancer come from? Well, it came from the Provera group, the medroxyprogesterone. And in that group, if memory serves, it was about an 8-fold increased risk in breast cancer for that group compared to the placebo group. That's where the breast cancer risk came from. Translation, don't give fake progesterone. Reasonable, but that was kind of overlooked in the reporting of the study. And finally, don't give horse pea estrogen to menopausal women 10 years after they go through menopause. Why is that? Well, women, when they have functioning ovaries that are cycling and are producing estradiol, have a great deal of cardiovascular disease protection compared to us dudes, which we don't have that much estrogen. So they have like anywhere from 3 to 10 times more estrogen than we do at any particular point of the month in their cycle. So that's a lot more estrogen. They have a lot more protection. When they go through menopause and the ovaries retire and stop pumping out estrogen, they're no longer protected. Guess what? Now suddenly they start to get the same risk of cardiovascular disease that us dudes do. So this experimental population had 10 years after menopause to grow coronary heart disease and atherosclerotic plaques. It's not surprising. Oh, and by the way, oral estrogen can be pro-inflammatory, and it can cause you to pop off little atherosclerotic plaques, and then they go downstream and lodge like a log jam in the river, and they plug up your vessels, and then you have a stroke or a heart attack. Not a good outcome. So a translation of the findings of the study would also be, don't give oral estrogen to women 10 years past menopause. Now, arguably, you could be more restrictive and say, don't give horse pea estrogen to women 10 years post-menopause, because that's what was done. But considering that we want to be safe, the rule of thumb now is don't give estrogen of any kind to a woman 10 years after menopause, be it horse pea estrogen, Premarin, or even bioidentical pills of estrogen orally. But there are different ways to take it. We're going to come back to that in a second. Progesterone is really easy. Progesterone is the hormone that gives women a wonderful ability to relax and be happy and sleep well at night. So the solution for treating a menopausal woman whose progesterone is low, and frequently that's the first thing that drops, is simple: progesterone pills. They are bioidentical. You take them, they go to the liver, they're metabolized into allopregnanolone, which is like God's benzo or nature's benzo, take your choice. And it's very relaxing and very calming, and you really sleep great on it if you're a menopausal woman. Very easy to do. We just have to go up in a careful escalating dose. So I would never start a woman on 100 milligrams a night of it. That when you start it and the woman hasn't had progesterone in her system for a while, that could really dope her up. So we start it really conservatively, 1 pill every 3rd night for a week, and then every other night for 2 weeks, and then every night. And typically when we get it to 1 pill a night, that gets the progesterone level up where it needs to be. So that's progesterone. Testosterone, that's more interesting. There are several ways to get testosterone into a woman, none of them FDA approved. Now, please keep in mind, estradiol pills, estradiol patches, progesterone pills are all FDA approved. They're in the PDR, the Physician's Desk Reference. They have the US FDA approval. So they're very regulated. They have in them what the manufacturer claims, and it's just kind of a no-brainer to use them, including the patches. Estradiol is curious. There are different practitioners who will hold themselves out as bioidentical hormone specialists. And I'm going to pick up a demo bottle of troches. We'll have a close-up of this. And this is from a local, reasonably local pharmacy. And this is what they look like. And basically a troche is something, or troche, you put it under your tongue and you let it dissolve. These are actually chocolate caramel cream troches. And these are placebos, so there's no active drug in here. But the interesting thing about estrogen is there are actually 3 different types of estrogen. There's an E3, an E2, and an E1. And the allegedly bioidentical practitioners that hold themselves out as specialists, and this is in the Suzanne Summers crowd and her disciples, they will have multiple types of estrogen in these troches. So they will have E3, which is estriol, which can help with hot flashes, but is totally worthless for cardiovascular protection or bone protection or heart protection, and E2, estradiol, and E1. And quite frankly, you don't need the E3 and the E1. The notion is when you pull estrogen from a healthy menstruating female, you have E3, E2, and E1 there. So the notion is, well, we'll just give her E3, E2, and E1. The problem with that is all you need to do is E2. So a troche of E2 will be just fine, estradiol. Now, there are also other ways to get estradiol into her. There is this device. It is called a Topi-Click. And when you turn this knurled wheel on the bottom, one turn, it'll go click, and 1/4 of an ml of whatever is in here will come out. And the wonderful thing about this is I always like to start too cold, in the Goldilocks and the Three Bears paradigm, too cold, and then I'll start turning up the heat, and we'll try to get it just right. And if we go too far, there'll be side effects, and the woman can literally dial it back down. So this is one way to do it. Another thing that happens with women in menopause is they will have vaginal dryness. And sometimes not even the estrogen that we would put on their skin or that they would take in pills, and there's another way too, even that won't do it, and they need something intravaginal. So this is called a Topi-Click Pearl. It works the same way. 1 click is 1/4 of an ml, and there's a little syringe that fits here, and you push it down, and it makes a good contact, and then you just click 1, 2, 3, or 4. It fills the syringe, the applicator syringe, to the desired level, and then the woman inserts it in the vagina, pushes the plunger, and it goes up in the vagina, and then you can get vaginal moisture. And it doesn't hurt to have sex that way. So this is another way to apply estrogen. We talked about the pills. We talked about the troches. We talked about the creams. There's only one other way, and that is pellets. So I brought along a set of, these are actually disposable tools. They've been cleaned, but this is the applicator, and I'll go over it. I'll go over it carefully. So the way pellets are put in, and you only have to have it one time every 3 months, they're in there. You don't have to remember to put creams on or patches or suck on troches or anything. You put the physician or healthcare practitioner puts them in, and they stay there. So as you can see, It's a really small device, and you'll also note it has a blunt tip. This is a patent pending device, and it allows us to put a small incision in a woman's backside, put this down and in, and when it's in and it's got a blunt tip so it doesn't cut, it doesn't hurt you, it doesn't cause tissue distress. When we have it in, then we will just undo this. We will load it up with the estrogen and testosterone. I'm getting ahead of myself here a little bit, but we can apply estrogen and testosterone this way, and then we put this in and keep pressure on it with the thumb and pull it out, and it just lays these pellets right in, and then they dissolve over 3 months. It's a wonderful technique. It's also great for men. So that's basically the way you can get estrogen in women. And then testosterone, I kind of let the cat out of the bag on that one. We can also put testosterone pellets in women, and I'll show you another device. We can also put testosterone in this. If I'm starting it and trying to adjust it, I can put testosterone in one of them and estrogen in another one, and let the woman use both of them and find her own level on 2 different things. And then when we know what feels the best and what looks good on the labs, then we'll just put both of them in one Topi-Click. So we got the estrogen and the testosterone in one device. It cuts the cost in half. So this is a really cool technique. And then I'll show you this one too. Another thing that we can do, once we have the exact dosing, we can put it in this, which is a mini mega pump. It's called a mega pump because there are larger pumps than this, and they're called mega pumps. And since this is small, it's a mini mega pump. Different compounding pharmacies call it different things. But with this, you push down, and one click is the total at one push, one pump is the total application you need. Let me see if we can get it here. So this is one pump, and I'll show it in close up. And since this is a placebo cream, there's no drug here, but this is what it looks like. And I'll just rub it into my hands. It's a placebo, it's a great hand cream, but you wouldn't want to use it for hand cream. So this is a mini mega pump. This is a Topi-Click. These are pellets. What I don't have to show you are the transdermal patches. They're prescription. They're sitting in a pharmacy somewhere. I don't have any that I can show and demo, but they are designed so that a woman can put them on her body in different locations. And the dosing is one patch applied twice a week. And what it does is it pushes estradiol through the skin into the tissues using osmotic pressure, and it works very well. You put it on after you shower or bathe. You do not moisturize in the area that you're going to put it on. You put the patch on twice a week and you're done. So that's kind of a quick review of the different ways to get hormones into a woman's body in menopause, and they can be adjusted up and down very precisely. Now, let's talk about how much this stuff costs. The absolute cheapest way to do it, if a woman is right around 50 and her menopause has been in the last 3 years, bioidentical estrogen and progesterone. They're generic, they're cheap. You can get them with GoodRx coupons, no biggie. For the testosterone, which you can't get with a GoodRx coupon, the cost will be anywhere from $20 to $40 a month, depending on the dosing and how creatively I prescribe it. And I prescribe it creatively. That's relatively inexpensive. You have to get labs. I have to see you to know how you're doing. We have to talk about side effects, but it's really inexpensive. The The Lexus or Mercedes option is pellets. They're very good. They are more expensive than the troches or the creams, but they last 3 months. There's nothing that you have to remember when you go out of town. You can't forget your meds because they're in you. You could forget your progesterone, but you wouldn't be forgetting the pellets that are inside of you. And so those are basically the options. Now let's talk about side effects. So I told you about how I would treat. What do you, as a woman, as a healthcare consumer, need to know about what you do not want to have happen? So progesterone, I told you, can be metabolized to allopregnenolone in the liver. Well, there are different steroid pathways, and actually progesterone can go over and some of it can be turned into something called aldosterone. Aldosterone is a mineralocorticoid, and it causes your body to retain sodium. That's a good thing if you need to. For example, if you are out running a marathon in blazing heat, your body needs to retain every bit of water it can. So the aldosterone will help you hang on to water. Unfortunately, if you're not running a marathon, the aldosterone can also help you retain water, and you will get fluid retention in your legs and in your body. You'll gain water weight. You might even get the dreaded cankles that some of my women patients tell me about, and that wouldn't be good. And you could feel doped and zombied out and hungover when you get up the next morning after you take it. No good. I don't like my patients to have side effects, and they don't like it either. So we just adjust the progesterone so you don't get those side effects, but yet you get a protective amount of progesterone. Speaking of which, back in the day when I was doing either Premarin or Prempro, the notion was if a woman didn't have a uterus, she didn't need the Provera, because she didn't have anything to protect, so just give her the estrogen. Well, as you may know, women have also, they have breasts besides uteruses. And so if I am putting estrogen in a woman's body, even if she doesn't have a uterus, I'm going to protect her breast with progesterone. So that's one of the things that I'd like for you to remember about that. In terms of side effects with estrogen, well, first of all, let's talk about the Goldilocks and the Three Bears. So for estrogen, when you look at it in that paradigm, the too cold bowl of porridge is you have hot flashes, you have night sweats, you're not thinking clearly, you're grumpy, maybe you're depressed, you don't feel like your brain is working right. And your vagina is dry and your skin is drying out and it's thinning out. That's too cold. Just right is none of the above. Your brain is good, no hot flashes, no night sweats, brain's functioning well, good concentration, good focus, good skin, and if your level is just really good, good, solid moisturizing in the vagina so that sex is no longer painful. If that can't be done with just moving your estrogen level up in the blood with creams or pills, then we could use an intravaginal cream, like I showed you the dispenser for. Too hot, very simple. Breasts and or nipples will be painful and or swollen. That's it. If you're having that, you know you're on too much estrogen. So that's the estrogen component. The testosterone component, that's pretty easy. So too cold, you have no libido, but mind you, there's more to testosterone in women than just treating libido. If a woman wants more sex drive, that's great. It is not my agenda to ramp her sex drive up to super high levels. No, I want the woman to feel comfortable with her libido. But that's one of the benefits of testosterone. Other benefits of testosterone include hanging onto your bone mass better, building muscle, decreasing cholesterol, and burning visceral adipose fat. Those are some really good benefits of testosterone, not to mention more energy, more enjoyment for life, more ready to go type stuff. So, wow, we covered a lot. So we talked about all the different dosing techniques. We talked about Goldilocks and the Three Bears for all three of these: estrogen, progesterone, and testosterone. We talked about the different cost for things. And I think that just about wraps up the treatment of menopause in terms of hormones. I think I'll come back and we'll talk about some other things, including you got to have vitamin D, you got to have DHEA, you have to monitor the bone health, but we'll save that for another occasion. So thanks for watching. I hope this was useful to you.